All right, it is 12:30, so we'll get started. So hi everyone, welcome to our September Environmental Health Seminar. My name is Tina Chen, and I'm one of the Environmental Health and Knowledge Transition Scientists at the National Collaborating Center for Environmental Health. For those of you on the phone attending as a group, because I can't see who's actually attending, if you'd like to receive Sci-Fi educational credits, please send me an email to confirm your attendance. I will put my email address in the chat box. So today we have Sally Maguet, who will be presenting her work with the BC CDC on public health planning for a wildfire smoke event. Sally is the owner and principal consultant for Context Evaluation Consulting in Vancouver, BC. She has designed, implemented, and reported on evaluations of complex, system-oriented initiatives in a variety of health programs and services, including mental health and substance use, harm reduction, Indigenous and environmental health. Working collaboratively and in partnership with service users, service providers, and decision makers, Sally uses evaluation as a tool to inform and guide research and planning to improve health services and outcomes on a provincial and national scale. So for those of you online, if you have questions for Sally, please enter your questions into the chat box and we'll get to them at the end of the presentation. Thank you. Now over to you, Sally.
Thanks, Tina. Thanks for everyone who's here in the room and for everyone online. I'd like to just start by acknowledging that I'm presenting this work from the traditional and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh people, which I'm very grateful to be on today. So I'm going to present to you today on work that I've been doing with the CDC for the last 2 years, looking at how public health practitioners and their collaborators are responding to and planning for wildfire smoke events. So the work I'm going to speak to today comes out of 2 reports that we've produced. One that was published last summer in August of 2018, which was the result of interviews with 4 Canadian jurisdictions, public health practitioners in 4 Canadian jurisdictions, asking them about their experiences with wildfire smoke events, what they had done to respond to those events, what they had learned in their experiences. And a second report that came out this summer, this August, where we went to 3 additional Canadian jurisdictions and 2 US states and asked public health practitioners about how they're planning for future wildfire events and the knowledge, capacity, and skills that they feel that they will need in the future going forward. So the 4 main research questions that we were thinking about in these 2 projects were, what are the most important factors for public health to consider when preparing for a wildfire event? How were forecasting and guidance systems used? How could they be improved? How were they useful? What have public health practitioners learned from their experiences responding to wildfire smoke events? And what capacity, knowledge, and skills do they think are required going forward? So in total, these 2 projects included 6 Canadian provinces, 1 territory, and 2 US states. So we spoke to people in a variety of geographical locations with different risks of exposure to wildfires, different health systems, different population densities, different population structures. And we spoke to public health practitioners. So this included people in the formal public health system, like medical health officers and environmental health officers, emergency managers, as well as folks who are supporting those people in the public health system, people like air quality specialists and climate change planners and municipal planners. So these are the main types of roles of the people that we spoke to. We did a total of 48 interviews. And we spoke to medical health officers, so they're responsible for giving guidance and advice to the public. They're also responsible for protecting the health of workers within the healthcare system during a wildfire smoke event. Emergency managers tend to take a role that is more closely related to hazards and risks associated with the fire itself. So they're responsible for setting up emergency operations centers. But there is also some overlap with smoke because generally the communities they're working in, if they're close to a fire, there's also going to be smoke issues. Health emergency managers are sort of a bridge between emergency managers and the health system. So they work with communities and health systems in advance of emergency situations to help them to prepare. They also sometimes provide emergency first aid and help communities to build resilience to be able to respond and recover from emergency events. Environmental health officers are part of the formal public health system, and they work directly in communities. So they were an important connection between communities and the health system and other systems that were involved in responding to wildfires. Climate change planners, this is a relatively new role that is coming up in some regions and municipalities. So we spoke to a couple of those. Air quality and environmental health specialists. So these often work, sometimes they work in health authorities, but they generally work in sort of regional governments and municipal governments. So we spoke to folks you can see on the map here in British Columbia, Alberta, Manitoba, Ontario, Nova Scotia, New Brunswick, Northwest Oregon, and California. So you'll probably recognize some of those jurisdictions as having extensive experiences with wildfires. So over the last year or so, 3 important reports have come out that all speak to the risk of wildfires with the advancement of climate change. In 2018, the Intergovernmental Panel on Climate Change released their really important report that was looking at the effects of climate change at 1.5 and 2 degrees Celsius. And they identified with medium confidence that there is a high risk of increased occurrences and severity of wildfires in Canada under both 1.5 or 2 degree increase in temperature, with an increased risk at 2 degrees Celsius. Environment and Climate Change Canada also put out a report in 2019, and in it they stated, or they found that the temperature is rising in Canada at twice the global rate. And they cited 2 studies that found that the risk of wildfire was increased in Fort McMurray in 2016 because of the effects of climate change, the risk of the fire that happened there. And just a few months ago, the BC Ministry of Environment and Climate Change Strategy put out their strategic report on climate change that also found that the risk of wildfire in BC is going to increase under climate change models. They found that the temperature in BC is forecasted to increase between 1.5 and 5.2 degrees Celsius by 2050, depending on emission scenarios and where you live in the province. The north is warming faster than the south of the province. And they also found that the consequences of fires that are predicted to be larger and more severe in BC will be major to catastrophic for health, environmental, and social sectors in the province. So the last few years have been really significant years for wildfire globally, and particularly in North America. 2018 was the worst wildfire season on record for British Columbia. 1.3 million hectares of forest burned in 2018 in British Columbia. Prior to that, in 2017, that had been the worst wildfire season, where we lost 1.2 million hectares of forest. And 65,000 people were evacuated in 2017 because of wildfires in British Columbia alone. In 2018, California saw the largest, most destructive, and deadliest fires all in the same year. The Mendocino Complex fire burned 185,000 hectares, and the Camp Fire destroyed almost 19,000 structures and killed 86 people. And in Oregon in 2018, there were 1,113 fires that destroyed 31,000 hectares of land. And this represents an 8% increase in the number of fires over the 10-year average, and a 120% increase in the area burned. In 2017, Canada had 3% fewer fires, but those fires burned 30% more forest than had been the 10-year average before that. And most people in Canada will probably remember the 2016 Fort McMurray fire. So this is known as the Horse River Fire. It destroyed 2,400 structures and burned almost 600,000 hectares of forest. And a review by Alberta's Department of Agriculture and Forestry found that the fire season in Alberta is becoming longer, starting earlier, and it's featuring more severe periods of extreme fire hazard. So, fires pose direct risk to communities and people and infrastructure, but the smoke from wildfires also poses additional risks, and it can affect large areas of land and large numbers of people. It's difficult to characterize the exact constituents within wildfire smoke because it depends on what's burning, it depends on the heat of the fire, it depends on the age of the smoke. But there are some consistent constituents within wildfire smoke that have known health implications. So nitrogen oxides are usually present in wildfire smoke, and these can cause short-term decreases in lung function and possible increases in respiratory infections. Carbon monoxide can interfere with the body's transportation of oxygen. Ground-level ozone can decrease lung function and increase airway resistance and cause coughing and wheezing. And what's most often considered when people are researching the health effects of wildfire smoke is particulate matter that's smaller than 2.5 microns, or PM2.5. This can cause exacerbations of asthma and chronic obstructive pulmonary disease, increases in respiratory infections, and possible cardiovascular effects as well. And volatile organic compounds have also been found in some wildfire smoke, and some of these are known carcinogens such as benzene and formaldehyde, and some are possible carcinogens such as furan. So exposure to smoke, so there is the issue of what the smoke contains, and then exposure to smoke is another factor that's hard to characterize in the wildfire smoke research because it depends on individual susceptibility, it depends on housing, it depends on where you work, it depends on what access you have to cleaner air spaces. So the reason PM2.5, or particulate matter smaller than 2.5 microns, is of concern is because they're very, very tiny particles that can go really deep into your lungs. So this is an illustration that's used quite often to show how tiny these particles are. The gray strand there is a strand of human hair, and the blue beads around it are PM10, or particulate matter that are smaller than 10 microns, and the pink beads around the blue beads are PM2.5. So they can go deeply into the lung tissues and also are thought to possibly be able to cross over into the blood vessels or the vascular system, causing cardiovascular issues. So a review of the literature in 2016 found that there was consistent evidence of exacerbations of asthma and chronic obstructive pulmonary disease during wildfire smoke events. The evidence for cardiovascular events is somewhat inconsistent. There's sort of more research coming out, but it's still somewhat mixed and uncertain. And that there's also some mixed evidence about an increase in respiratory infections, although there's more evidence coming out that there's likely to be a connection between that and wildfire smoke exposure. So just to give you a sense of the kinds of exposure that we're thinking about when we're thinking about wildfire smoke events, I'll give you the example of Williams Lake. So Williams Lake is located in the southern central part of British Columbia, and it was quite severely impacted by the wildfires in 2018. So this graph, this was taken from the BC Ministry of Environment. They have historical data from air monitoring stations around the province. And this graph shows the daily mean PM2.5 concentrations across the month of August in 2018 in Williams Lake. So just to give you some context, the World Health Organization recommends exposures no higher than 25 micrograms per meter cubed over 24-hour average. Canadian standards are 27 micrograms per meter cubed over 24 hours. It's 28 right now, it's going to go to 27 in 2020. And in the United States, their sort of standard is 35. So that's the point at which public health departments would be expected to possibly take some action to protect the public or communicate to the public about the risk. And in Williams Lake, in 2018, their highest average mean PM2.5 concentration was on August 17th, when there was 528 micrograms per meter cubed. And 18 out of the 20 days in August, which they had data for, you can see this little gap in the middle there, 18 out of the 28 days were above the Canadian standard of 27 micrograms per meter cubed. And in 2017, same community in Williams Lake, over the 2 summer months of July and August, the average daily exposure was 70 micrograms per meter cubed for those 2 months. And 37 of those 61 days of those 2 months, the average daily exposure was above 27 micrograms per meter cubed. And sometimes the data is actually a little hard to sort of get your head around. For instance, there was a study that came out that showed that in Fort McMurray in 2016, the maximum hourly, so this isn't for a day, but it's a 1 hour time interval, PM2.5 concentration was 6,106 micrograms per meter cubed, which is actually kind of hard to imagine. So having spoken to people across the country and in a couple of states in the US, we learned a couple of things that were really important that came out multiple times from speaking to folks about what is really important to think about when planning for a wildfire smoke event. So one of the things that came out loud and clear is that it's important to be prepared in advance, to have communications materials ready to share with the public and to share with healthcare providers. But it's also important to have sort of a hub where people know they can go and find that information. One of the challenges that was expressed quite a few times was that people didn't know where to get the right information. The public didn't know, but the healthcare system didn't know either. The public healthcare system or primary health providers didn't know where to find the information. And to create and foster connections and relationships across different sectors and different agencies was really helpful in gathering information, but also putting information out, so it was both ways. Deciding on communication channels and building some communication pathways and infrastructure was really important in terms of public health departments getting the message out to communities and to primary health care providers. And building the capacity in rural communities, particularly larger rural communities that are likely to be receiving evacuees, was something that a lot of people spoke about, and there were many, many factors involved in this. So connecting evacuees to primary health care services if they arrived in communities, having mechanisms to identify high-risk people who are going to be at increased risk if they're taken out of their homes and taken away from their home environments. Connecting with pharmacies and primary care providers in evacuation receiving communities. Also preparing communities and particularly the healthcare sector to be able to provide culturally safe and welcoming services was identified many times as an important consideration. And considering mental health planning right from the very beginning of emergency planning. And often, so practitioners identified that often mental health was a little bit of an afterthought, and people were thinking about mental health impacts after an emergency, but in fact the mental health impacts start from the very beginning of the emergency, and it can really affect people's decision-making processes during an emergency. So this was brought up by almost every jurisdiction that we spoke to, is considering mental health in emergency planning was extremely, extremely important. And connecting with communities to understand what mental health resources are available to people was also flagged as something that was really important. Educating health practitioners on the impacts of wildfire smoke. So some communities had reported that the primary healthcare providers were not sure how to advise people on how to protect themselves from smoke. So, you know, more education campaigns or literature or published resources were thought to be helpful for that. And also for health authorities to consider encouraging their staff to prepare for an emergency and to think about how to prepare their families for an emergency, so that if an emergency happens, that they will be available to still be at work and not have to be caring for family members who might be struggling, particularly if they have respiratory illnesses or concerns. That was also flagged as something really important. So there are forecasting systems and guidance, public health guidance on wildfire smoke that is continually evolving with research as it comes out and with technical expertise as it's developed. On the right, you have the Blue Sky forecasting system that we have here in Canada. It's available on the Fire Smoke website. This gives you a 48-hour forecast of the movement of smoke across the country. And in the United States, the United States Environmental Protection Agency is developing this public health tracking network. And they have this tool that they've developed on the left here, which gives you 24-hour smoke forecast and overlays it onto socioeconomic data in communities, so you can have a better idea of at-risk communities in regions and states. And you can access that on different levels as well. So to the county level, to the state level. That was just released this year too. It's a new tool. There's also public health guidance in most of the jurisdictions that we spoke to on how to respond to wildfire smoke and protect yourself from wildfire smoke. The first document that came out in North America came out of the US EPA in 2001 in response to record wildfires in the states that consumed 8.4 million acres or 3.4 million hectares of land in the year 2000. And they've updated the recommendations several times. This is the one from 2016, and a new version came out this year in 2019. And then several jurisdictions in Canada have also developed their own sort of region-specific guidance. Most of it is based roughly on the guidance that came out of this document. So we have something in Alberta, British Columbia, Manitoba, Newfoundland and Labrador, Northwest Territories, Quebec, Saskatchewan, Yukon, and Oregon. They all have their own specific wildfire guidance. So the sort of overarching general public health advice during a wildfire smoke event is to avoid exposure. So this means staying inside, This means reducing physical activity if you have access to air filtration systems like HEPA filters, that's also helpful. And in some places, although the advice varies, some places advise folks to use N95 masks, although that advice is given with extreme caution because there are a lot of factors that might make folks feel more protected than they might actually be with an N95 mask if it doesn't fit properly or if it's not an actual proper N95 mask. So when we asked folks how they use forecasting systems and public health guidance, they told us that it was really helpful in raising awareness in communities and among healthcare practitioners. They said it was good to, the important thing was to raise awareness of these sort of alert systems like the AQHI, which is the Air Quality Health Index, which, thanks Tina, was developed primarily for industrial air pollution and urban air pollution, but has some usefulness during wildfire smoke events because it does have track PM 2.5 levels, and so it can give people an idea of if the air quality in their region is really something they need to be mindful of, depending on what their health status is. Another really important thing that we heard about in one of the jurisdictions here in BC was respiratory therapists working directly with patients to educate them and prepare them in advance of an event. So having access to folks who may have additional vulnerability to wildfire smoke events, so folks with asthma or chronic obstructive pulmonary disease or other respiratory conditions, really being mindful of what they need to do to prepare for an event so that they can prevent some of the worst outcomes that can happen. And again, familiarizing practitioners, so primary care practitioners, public health practitioners with the guidance that's available was helpful, just having them be aware of what's already out there, not having to create new guidance specifically. And in a lot of remote and rural communities, they don't actually have air quality monitors, and so they had to use alternate decision-making processes. So things like visibility assessments. So if you plan ahead of time and realize that a certain landmark is so many meters or kilometers from where you're going to be standing, and then you can translate that into if the smoke is at a certain density, you'll have sort of certain visibility. It's a rough estimate of the air quality that you're experiencing and whether when you want to alert the community and the public to be taking extra caution. But to decide in advance how you're going to make those decisions was really important and helpful, because one thing I heard many times is trying to decide these things and put these things together during an emergency is really difficult, And considering working with non-health agencies, so there was one jurisdiction where they were working with hydro crews to put up air monitors and monitor air monitors, because they actually require some maintenance and technical expertise to keep them going. So in remote and rural areas, you may not necessarily have someone within the health system who has the capacity to do that. So sometimes working with sort of unconventional partners was helpful, just to sort of keep your mind open to whoever might have the capacity or the ability or the access to those places. And the most important lessons learned is that health authorities, it was really helpful when they had an actual connection and relationship with community leadership, so municipal leadership and communities. Sometimes this was through NGOs like the Red Cross. Sometimes this was through environmental health officers. Sometimes it was through connections with actual sort of leaders in communities, mayors, chief and council, that type of thing. So, and an issue that came up a lot too was how public health departments were working with emergency responders. And the message that came out there was really that, again, during an emergency and during an event, it's very hard to create relationships and figure out how you're going to work together. So where public health departments were involved in emergency planning from the beginning and ongoing and sort of understood how those emergency responses were going to roll out and could be a voice at the table in emergency planning as to some of the health considerations, that was how it was most effective. Although during a severe smoke event or a fire, most public health departments said that they really just stepped back, let the emergency responders and the emergency management folks do their thing, and were basically more responsive and proactive in being involved. Another thing that we heard a lot was that simply advising people to stay inside over long periods of time was not effective at all, for many reasons. Partly because if people don't have some sort of air filtration system in their house, the air quality inside a house is not very different than the air quality outside a house after a few days of smoke exposure. People also may have issues with the quality of their housing, and usually fire events coincide with extreme heat events. And so there's actually a lot of safety concerns with asking people to stay inside and closing their doors and windows when there's also extreme heat. And what I heard often too was when you have these extended smoke events, like over days, weeks, and even into months, is people start to no longer listen to the advice, and they sort of go back to their usual way of doing things, and they're not really paying attention anymore because they feel like they just need to get on with their lives and sort of go back to their regular activities. The hope and the ask was, if it's possible to develop advice or strategies that people can use that can allow them as much as possible to continue their life as usual, go to work, get out and be with their family and their community. That was thought to be preferable to asking people just to stay inside in their homes. And so when one of the things that has been considered and tried in a couple of jurisdictions is creating publicly accessible community cleaner air spaces. They have been called clean air shelters by a lot of folks, and some people have flagged that as having negative connotations for people. A lot of people don't want to go to a shelter because they associate it with sort of people with high needs of social and health care, and if folks don't feel like they fit into that population, they don't really want to go to something that's called a shelter. So changing that to frame it more as a clean air space was seen as something that kind of opened people's minds to wanting to go. But there are many complex issues with creating and making accessible a clean air space. So there are a lot of equity issues in terms of people being able to get to a cleaner air space, people being able to access it if they had physical limitations, if there were costs associated with people getting there. And then once you have folks there, you need to think about access to water, access to washrooms, capacity issues. It's a very complex thing to set up, actually, and often usually the cleaner air spaces that people have tried to set up were in public infrastructure like schools, community centers, hockey rinks, that kind of thing. Some jurisdictions experimented a little bit with private infrastructure, things like shopping malls, but that was a little more challenging and difficult and complex. So this is an area that's still very early in its development, and there isn't really a lot of guidance on how to do this. And the other thing that came up was to attempt to have consistent messaging from public health departments, advocacy groups, media, and allied health practitioners. So again, that probably goes back to the education issue. So some jurisdictions were finding that the messaging that was coming out of public health departments was inconsistent with what was coming from the media and was inconsistent with what was coming from advocacy groups, which was confusing people and they weren't quite sure how to respond. So the media in particular were seen as a really important partner in communicating to people about how to protect their health. But media outlets don't have the same responsibility in terms of protecting people's health as health departments do. So it was more a matter of developing a relationship and working with media outlets to help them to give people the right advice. And also working with facilities, healthcare facilities, to create better and cleaner air within healthcare facilities is also another area where public health has been working. So there are a couple of jurisdictions that have done this. So there are a couple of approaches that public health has taken to do this. One, if buildings are a little bit newer and they have the capacity, actually adapting HVAC systems to be able to filter out more particulate matter was possible. So this required a lot of careful monitoring of sort of the pressures within the HVAC system and switching out the filters frequently. So it was a lot of work, but it was possible and it was doable, and early sort of reports were that it was quite effective, that staff was really happy to be able to work in a cleaner air environment. In older buildings where that may not be possible, some jurisdictions tried just bringing in air scrubbers. Wasn't seen as ideal, but in most cases when folks couldn't get to an ideal state, they just did what they could to make it better. And it was generally sort of seen as better than doing nothing. So the capacity needs that were identified through this project were research into long-term exposures to wildfire smoke. So long-term in terms of, you know, when we were speaking about Williams Lake, 2 months of very, very high exposures or repeated exposures year after year. There's very little research on that currently, and it's a very big gap in the evidence at the moment. Guidance and research into the implementation of cleaner airspaces, as I was mentioning, that's something that is also has a lot of work to be done there. And guidance on improving air quality within healthcare facilities. So how to adapt an HVAC system, how to prioritize which areas you want to clean the air. And developing and implementing climate change and health vulnerability assessments. So these were actually seen as a really great opportunity to open conversations with communities and community governments, and to create relationships with communities, because often these consider sort of infrastructure and you know, very sort of community-based needs. So that was seen as a really great way to open a conversation. So if you would like to access the 2 reports that this presentation is based on, you can find them at the NCCEH website here. They're free and available to anyone to download and read. You can also email me at sallymaguet@cdc.ca.
Thank you, Sally.